All right. We're going to go ahead and get started, everybody. Thanks so much for joining us for Grand Rounds. My name's Bryson Keith. I'm one of the internal medicine chief medical residents. I have the pleasure and distinct honor of introducing our speaker today. So this is Raja-Elie Abdulnour, MD. He's an associate physician in the Pulmonary and Critical Care Medicine Division at Brigham and Women's Hospital in Boston. He is also part-time assistant professor of medicine at Harvard Medical School, where he is involved in workplace medical education for medical students, residents, fellows, and faculty in pulmonary and critical care medicine and clinical reasoning. Dr. Abdulnour strongly advocates for lifelong medical education and is passionate about the safe use of artificial intelligence in education and patient care. He is a highly cited researcher currently working on AI's application in healthcare and education. Dr. Abdulnour obtained his Doctor of Medicine from the American University of Beirut and completed his residency in internal medicine at Johns Hopkins Hospital, followed by a fellowship at Harvard Medical School. He is board certified in critical care, internal, and pulmonary medicine. Additionally, he serves as the editor of clinical development and AI innovation at the New England Journal of Medicine Group and the editor-in-chief of the New England Journal of Medicine Journal Watch. Please welcome Dr. Abdulnour. Thank you.
Thank you. First, testing that everybody heard, microphone's working, fantastic. So it's a real pleasure to be here. I want to thank Dr. Punjabi, Dr. D'Amico for inviting me here, Dr. Weiss, everybody. I'm going to talk about a topic that I'm very excited about. I may be over-enthusiastic. There's a 100% chance I will confabulate today. I urge you to pick up on that and give me feedback and have a conversation. This sort of image on the right here represents sort of the many hats that I've acquired after sort of my traditional education, and so by going after opportunities, you acquire expertise in different things that I didn't think I would. But today the topic is around the natural language of clinical problem solving, and it's really more about a little bit of the journey of what I've been through and trying to outline some of the things I've learned and share with you. Some disclosures. So I'm a full-time employee of the Massachusetts Medical Society, and within it, the NEJM group, who publishes the New England Journal of Medicine, in addition to other journals, including NEJM Journal Watch. I initially was there and I developed NEJM Healer. NEJM Healer is a virtual patient case-based simulation to teach and assess the steps of clinical reasoning, recently acquired by a commercial company called Lecturio. I don't have any financial conflicts of interest. I don't get anything from them, but I still advise them on incorporating AI-based tutors, AI-based coaching, and AI-based assessment in the context of education. I'm also a consultant at Lumeris, a value-based care company. Again, trying to think about how can we leverage AI for value-based care purposes. I am not a computer scientist. I am not a data scientist. I'm a physician scientist by training and a passionate educator and a techno-optimist. So the outline is, so the problem gap hook I'm going to be talking about today. So the problem is diagnostic error. And within it, try to explore a little bit what is diagnostic excellence and the diagnostic process. And the gap here is that we have, on one hand, we have diagnostic error. And then on the second hand, we have this emergence of an AI problem-solving assistant with a potential impact on diagnostic excellence. And so the hook is, how could we bridge that gap? How could we leverage artificial intelligence towards diagnostic excellence? So first, I'm going to start by the diagnostic process. What is the diagnostic process? Well, this is adapted from the 2015 National Academy of Medicine document around improving diagnosis, and where they schematize or illustrate the diagnostic process as follows, which is really a series of a set of different problem-solving tasks from the moment a patient experiences a health problem, which is in itself a problem-solving task, or towards then accessing the clinic, encountering a clinician where there's the actual diagnosis that happens, the actual clinical reasoning that happens, and then there's communication of that diagnosis back to the patient and to the health system, initiation of treatment with then information flowing back to the patient and the clinician in this iterative fashion, and ultimately driving outcomes. Every single step here is in itself a problem-solving task, and diagnosis being one in particular. It really requires collaboration and is all patient-centered. I'm going to sort of spend a little bit of time thinking about problem solving, and it's going to be a little bit of, for lack of a better word, I'm going to nerd out a little bit. But so let's think about what is problem solving. Well, problem solving, which is something we do every day, all the time, in all contexts, really starts by data. So we acquire data, or data is given for us, or we actually look at data. And the first thing that happens is, if you just look around the room, there are billions of individual pieces of data, but then your brain sort of embeds it, summarizes it, and synthesizes it, and embeds it into smaller representations of the world. And so here you can see, I'm sorry. And so here you can see these, what I'm trying to represent here is that our brain embeds this information into higher order concepts or pieces of knowledge, and then these are further incorporated into a problem. Okay, so for example, I'm walking in a jungle, and there's all this data coming in, and then I see this like orange, furry, big thing that's growling. It's a tiger. So I represent the problem in front of me. And that representation of knowledge requires a knowledge graph. We need to have a pre-acquired knowledge to know how to associate all this information. And these associations of data are probabilistic. I mean, the fact that something is orange and furry is a tiger is actually a probabilistic association. And very quickly after the representation, there is a diagnosis. There is, okay, so this is what's going on. So this is what I'm seeing. I think this is a tiger in front of me. And so there's this sort of deduction step that happens after the inductive reasoning process, where I have a hypothesis onto what's going on. And the way we organize our knowledge around the hypothesis is around scripts or problem scripts. For example, I'm hungry. So that's a problem. And to solve it, I activate multiple problem scripts. Do I order through Uber Eats? Do I go to the restaurant? Do I walk to, do I call in for a takeout? All these are problem scripts. And they're actually a way for us to organize our knowledge fund, which is represented down below, into these scripts, which are like stories. And scripts have, they have predisposing factors or the setting. So this is sort of the context around you. The actual pathophysiology or the fault, I'm hungry. And then consequences. I feel bad. My belly's growling. And then there's part of the script is a potential solution or a denouement to the story, which is one script I can use Uber Eats. Another script I can drive to the restaurant, etc. And so I activate that script, and you can see what I'm trying to represent here in this image is sort of an organization of knowledge in our mind, where although sort of the neural network in our mind has these associations, this deep neural network and semantic clustering of information, in fact, they're more organized like scripts that we pull when needed. And then once I've identified my script and I have a diagnosis, if the certainty of my diagnosis is high enough and passes a threshold of actually making a decision, so passing a treatment threshold, then I activate the script and I go for a solution, which is the activity. Now, problem solving, like I said, it's all around us. It happens every day, whether it's IT people trying to solve a particular problem, whether it's a patient trying to figure out how to access the clinician, or a clinician trying to make a differential diagnosis. And so, in fact, diagnosis, to hone a little bit, is a subset of this is clinical problem solving. And the difference is as follows: is similarly, it starts with an input of data. There's an inductive reasoning process that leads to a problem representation, which very often is actually subconscious, and after which there is a deductive reasoning. Now, deductive reasoning or hypothesis generation, there's this dual process theory that happens. So as an example, so I'm going to actually use my hand. So as you can see here, data has been represented. There's a problem representation. For example, acute chest pain in an elderly man with cardiovascular risk factors. Right? That's a problem representation. And so then, okay, so that's going to activate, actually, it's going to I'm going to go and start pulling scripts that match this. If I'm the problem in clinical reasoning is that, in diagnosis in particular, is that this problem representation is actually, it could belong in scripts, in illness scripts, and these illness scripts can be very complex and very deep and very nuanced and very detailed. So, for example, we could, I'm a pulmonologist and I work in the critical care, I actually have different illness scripts for acute respiratory distress syndrome, ARDS due to pneumonia, ARDS for a patient who's been 2 weeks on the ventilator, ARDS due to COVID. Each of these are sort of like really detailed illness scripts that I can use when I see the problem. I want to pause a little bit here on this fast and slow thinking. So again, I'm going to, from the beginning, I have data, right? I'm reading a chart, I'm asking questions. If I'm very familiar, so if somebody comes and says acute hypoxemic respiratory failure, COVID positive, bilateral infiltrates, I don't even have that step. Boom, I go straight because I'm familiar with this problem. I go straight into a differential diagnosis. But if I'm unfamiliar, that's when I take a diagnostic pause and I slow down and I use an analytical reasoning. And this is where the problem representation is essential. The problem representation is what I will use to activate my differential diagnosis. And so that's the dual process theory. And this here is really sort of the most well-accepted model of clinical reasoning. And so either system 1 or system 2, I build a differential diagnosis centered around the problem representation. So these are the 3 diseases I'm considering. And so this is my differential. And each one of them, I have like a baseline probability. Like there's a likelihood that each one is correct. And to really know, and you can see here that the probability really falls under, like I'm not sure I can treat yet because it hasn't passed my treatment threshold. So what happens then is that I need to fill in these gaps. I need to acquire data to instantiate these different illness scripts. So that's when I go back and get more information, again, leveraging my fund of knowledge. I like the word wayfinding. There's a very nice paper by Adler-Milstein, where they represent diagnostic reasoning as wayfinding, finding your way through data, and that represents it. And then at some point, though, you may pass, for example, for this can't miss disease here, you've passed the threshold to order a test, and so you don't order the test, and that iterates. Okay. Now, the problem is that process is highly stochastic, meaning, as you can see, every step of the way, all these association of knowledge, these differential diagnoses are all based on probabilistic associations. Sometimes the probabilistic association is 99%, right? So SARS, if you test positive on a SARS PCR and in the right patient, it's a 99% chance that this is COVID, but it's not. I would argue it's never 100. And so it's a very stochastic process. And also, if I give one clinician the exact same problem multiple times, it's quite likely that I may have different answers at each time. And the differences may be subtle, obviously. Second, it's really dependent on our knowledge, right? It's dependent on our representation of the world and the sort of neural network, which is really how we grew up. It's all our experiences, where we were, our context. And there's really a possibility of acquiring wrong knowledge. I'm going to give an example. When I came to the States, and I don't know if it's a good example, but it's a real example. So when I came to the States from Lebanon, where the vast majority of our patients, in fact, the concept of race is not a concept in Lebanon. And then when I came to Hopkins and I went to residency, race was part of the problem representation. So this was this is a 25-year-old black man with X, Y, and Z. And it was, we used it fairly commonly. And for sure, it was associated with a risk of HIV, a risk of drug use. And I acquired it, and it became part of my knowledge, even unbeknownst to me. And it's only later through learning about social determinants of health that I've been able to extract that wrong knowledge and then therefore separate it, but instead of it being the fact that the patient was black or male, but it's the fact that they live in an underserved area, they're poor, and then there's systemic racism. So like unpacking that knowledge is critical, and there's a very high risk of error here. And then the other thing is that it's a situated process. If I'm reasoning at 2 a.m. in the emergency room on the same patient that I see the next day at 8 a.m. after a fresh night of sleep, this process is going to be highly affected. So that's why diagnostic errors happen. Diagnostic errors always happen. It's going to be, I'm going to show you the data. And so what is a diagnostic error? The definition from the National Academy of Medicine from 2015 is it's defined as the failure to establish an accurate and timely, so there's time that's important, explanation of the patient's health problems, or communicate the explanation to the patient. The communication step is critical. You can have the best clinical reasoning, you can be super accurate. If that diagnosis is not communicated, it's not going anywhere. It's like perish or publish. And so, it said that most people experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. I want to check on time. Now, another way that I like to describe it is by Hardeep Singh, which is the concept of a missed opportunity. So if you think about the world of errors, which is this square here, missed opportunity refers to these instances of a diagnostic error where something could have been done, like a diagnosis could have been made earlier, an intervention could have been done as opposed to another one. And then sometimes these missed opportunities can actually lead to harm. And so it's really, these are the ones that we want to capture. Sometimes error happens where there's no missed opportunities. It's just sort of the nature of the beast. These are still important to track, but it's really the missed opportunity that we need to follow. Okay. Now, let's talk about the burden, like how impactful are diagnostic error. So this is coming from work by David Newman-Toker from Hopkins, a neurologist, who has done a line of research really looking at big data to try to identify what are the major causes of misdiagnosis. And in prior publications in 2019 and 2021, he identified the big three, meaning that the vast majority of misdiagnoses are related to actually common diseases, infection, cancer, and cardiovascular disease. So the big three, and which account for 2/3 of missed opportunities and error. And so then what his group did is that they estimated the annual incidence of these big three, and then from it calculated the incidence of the yearly incidence of diagnostic error, and came up with what I found was a bit of a staggering result of an annual serious misdiagnosis-related harm, meaning death or permanent harm of 795,000 events in the US. This is way higher than what you would read in from the 2009 IOM report of 40 to 80,000. And in fact, so this is a range, and this is of course over everything this is extracted, is the range is between 598,000 to 1 million a year. So pretty high. And then among these 371,000 deaths, so which is third after cardiovascular disease and cancer. So it's common. It has a significant burden on our community and our society and on patients. Now, how about inpatient? So this is a study that came out this year. Here they did a retrospective study of 29, it's actually pretty tour de force, a retrospective study at 29 academic centers in the US. And they got a random sample of adults that were hospitalized with general medical conditions and who were transferred to the ICU, who died, or both. So really the sickest of the sick in the hospital. And then they wanted to see how often did diagnostic error happen in these patients, and how often did they contribute to harm? And so they isolated from that group 24,000, so 5% of this population, randomly selected, and screened 2,428. Next, each record, and so it's a lot of records, was reviewed by 2 trained clinicians to determine whether a diagnostic error occurred, either a missed or delayed diagnosis. And to that, they used a validated tool called SAFER-DX, which follows a root cause analysis to try to see if there's actually been an error. And then they identified diagnostic process faults. So a diagnostic process fault is where I made a wrong assessment or I ordered the wrong test, which may or may not cause an error, right? So they're 2 different things. And they used this framework called diagnostic error evaluation research and to classify harms. And then they estimated the association between a process fault and a diagnostic error. And then they estimated the opportunity for a diagnostic error reduction associated with each fault. In other words, how much do errors of test interpretation contribute to bad outcomes? So what they found is that 23%, so almost a quarter of the sickest group of patients experienced a diagnostic error. In fact, 22.7% of these patients, right? So 22.7% of the patients who died or transferred to the ICU, so the ones that really got in bad shape, experienced a diagnostic error. So pretty high. Then when they looked at the process faults, so I'm going to just orient you a little bit here to this table, right? So on the left here are the diagnostic process. So access or presentation to healthcare, taking history, physical exam, testing, patient follow-up, teamwork, communication, assessment, right? And then they looked at how frequently these errors were in total, which is the first column. Then in patient that had no error versus patient that had an error. And then they looked at the attributable relative risk, meaning how much did that particular process fault contribute to harm. And what they saw is that these 2 in particular, so assessment and testing, significantly, so errors in assessment and error testing had a significant contribution to diagnostic error. And so in other words, if you improve assessment, so the sort of the, one could surmise or hypothesize is that improving assessment and improving interpretation of test results may reduce harm. These are, I'm not going to go through these, but these are examples from the paper, which I think I've shared with you. If not, I'm happy to share, of examples of these errors. Just to focus on assessment at the right here, I'm just going to read it. This is an example of an error in assessment. A patient with recently diagnosed hepatitis C associated vasculitis was admitted with hematochezia, thought due to NSAID used for pain, along with moderate anion dab acidosis. The patient was transferred to the ICU with continued acidemia, encephalopathy, and hypoxemic respiratory failure, initially ascribed to non-cardiogenic pulmonary edema or pneumonia. Salicylate toxicity, which was not considered at admission, was diagnosed after ICU transfer by serum salicylate levels. This is an example. I don't remember the last time I had a patient with salicylate poisoning. Maybe it's because I haven't looked. It makes me wonder. Okay, so the National Academy of Medicine then came up in this report with stating that improving diagnosis is a social imperative, and that's really what drives me. That sort of has sort of drives me is how can we improve a diagnosis? And then they identified these goals, which when I first started working on this a few years ago, there was only one of them, which is education. But now I'm seeing myself thinking about everything. But when I first started thinking about this, especially in the context of my work at the National Academy, it was really around enhancing healthcare, professional education, and training in the diagnostic process. Okay. Let's geek out a little bit more here. So how do we learn? Well, we learn through practice. I mean, let's face it, we learn by doing. And so this is the problem-solving process I described earlier. So we learn by two ways. One, supervised learning. And I'm saying supervised not in the sense that somebody is supervising you, but you are given knowledge that somebody else has labeled. For example, you read a chapter about asthma. Somebody said that that information is asthma. So that's a form of supervised learning. And so this is how you build a knowledge farm. This is not through practice. This is sort of a transfer of knowledge, which is really unique to humans. I should not have said that probably, because I don't know, maybe I think other species do. The second is through practice and actually looking at feedback, getting feedback from your actions. And so if you're doing a problem-solving activity, if you don't know what happens, the unknown outcome, like let's say you started antibiotics and then they lost to follow-up, you're going to keep on doing the same thing. It's not going to affect your learning. If there's a favorable outcome, then it's going to reinforce that learning. If there's a negative outcome, you're going to calibrate your learning. And that's a form of unsupervised learning. This is you sort of just learning in the wild. Now, the problem, obviously, is that there's a very high risk of getting false knowledge. For example, a prior assessment of dermatology atlas books showed that 95% of images were images from white patients, right? So if this is the only book that you're going to read, your knowledge is going to be flawed when you're going to be faced with patients that are not white and then have skin issues. And then same thing about learning through practice. If you're going to do the same thing, this was like me sort of working at Hopkins and learning that incorporating Black race in the problem representation is important. That's a form of unsupervised learning that did me a disfavor. And so really the key thing is you need an educator. And so this is the learning through deliberate practice, where you actually get feedback on your practice to reinforce the positive aspects of your learning and de-emphasize the negative aspects of your learning. And so how do we how do we become proficient? So this is sort of adapted from Erickson's model of expertise. So, on the y-axis is clinical reasoning activity proficiency, which you can put it here, baking a cake, right? It could be anything. And on the x-axis is time. Well, the ideal path is that through deliberate practice, we learn and then we achieve expertise over time. But the reality is that the learner journeys are not the case. And that's because the exposure to educators is actually very heterogeneous. You all are lucky that you have exposure to good teachers and good coaches most of the time, but not all the time. And then there are some places where there are no exposure to a good educational system, which leads to different learner journeys. Some learners stagnate. Some do very well in class, but then once they're unleashed in the clinic, then they don't do well. And some really aren't supported and they're missed. And so in the traditional educational system where we have this time-based certification, if you finish 4 years of med school, you're good. If you finish 3 years of residency, you're good. You're going to miss out on these. And so, which is why the education system is moving towards this competency-based medical education, which fundamentally means follow the learner throughout their journey, assess them all the time, give them feedback all the time. And then ultimately, at some point, as we assess, they're going to meet a threshold above which you can say, I trust them to do that task. And this is why this is the role of these competency committees that decide on whether or not to trust a learner on a particular task. So I could be trusted in doing bronchoscopy, but I'm not trusted to put a swan gas catheter, for example. And so like the vision that we need to aspire to is a vision where we have a coach/tutor at all steps of the problem-solving process. Somebody that's going to give us feedback on the data we acquired, give us feedback on, did we represent the problem well? I mean, there are times I'm in the ICU where a third-year resident comes, perfect clinical reasoning, but their problem representation, what they chose to focus on, is nowhere near what the patient is struggling with. And so it's how do we bring in this? And so really, when I think about clinical reasoning in particular, it's really about a cognitive apprenticeship. It's an apprenticeship. It's deliberate practice in thinking. And the challenge in clinical reasoning is, well, how do we express it? How do you show what's in your black box? And so one thing that we've done through the work at NEJM Healer is to convert these sort of these dark skills, the art of clinical reasoning, quote unquote, into activities that we can actually assess and score and give feedback on. And I'm going to skip to here, but some of the big goals of educators is educational continuity. I want to make sure that my learner, that when they first come to medical school all the way through residency, we can track and see what they do, and so we can deliver them precision education, the right educational intervention to the right student at the right time, which is sort of taken from precision medicine. So precision education is what we want to aspire to. And then I'm also interested in teaching the diagnostic process. How can you teach the diagnostic process if you're not directly with the learner? It's very, very challenging, especially at the bedside. And then these are sort of the challenges, is that education is highly discontinuous. I mean, if I'm working with a student for half an hour, for half a day each week, it's a discontinuous process. They're working with different educators of different calibers, so on and so forth. And so one solution was to create a simulation-based longitudinal integrated clerkship, which is the work I did at the NEJM for NEJM Healer, where we broke the reasoning process into observable activities. I'm not going to spend a lot of time on this, happy to do so. But basically, we created these virtual cases where we broke a case into 4 boluses of data. And at each step, we asked the learner to express their clinical reasoning by saying what data is important, writing a problem presentation, generating hypothesis, instantiate illness scripts using a Venn diagram tool, write a diagnosis, make a diagnosis, then write a management. And so these are screenshots from it. This is the illness script thing. And at the end, this is the key thing, is we get all that data, and then we represent it in numbers, and then we give it to the learner along with feedback. And then that gives you sort of big data to then you can use and assess. You don't really care about these students. I mean, you care, but like these students that are in the upper quartiles, I think require less time, whereas the learners that are in the lower quartile may require more intervention. So that's a way to provide precision education for your learners without having to stretch yourself in space and time. And then something happened. So I was in the office of Zach Kohani, who's the editor-in-chief of NEJM AI, a brilliant sort of computer scientist at HMS, and he was showing him Healer, and then he goes, this was November 2022, he goes, well, what if there's a tool where you take all this information, you just give it to it, and then within 5 seconds, it gives you a complete problem representation, a differential diagnosis, the whole thing. I'm like, no way, that doesn't exist. And then a month later, ChatGPT was released, and then I realized that's what he was talking about. And in fact, Zach had already written a book about ChatGPT with Peter Lee, and so it's good to be in the know. And so that's where it's sort of, in my mind, I started realizing the potential here. And I'm going to try to explain why I think that large language models are unique. And that's because, so first of all, if you think about AI in general, AI is really very similar to what we do, which is to take data that's been input and then embed it to the point that you classify it and label it as a diagnosis. And you can express it as a differential diagnosis, again, all probabilistic. Now, traditional AI, which is unimodal, typically just stops the classification, then you can add to it other software to do additional things. But large language models are different. I'm going to explain why. So I encourage you to watch a talk by Yuval Harari, an Israeli historian who in my mind, has written what for me is the New Testament, *Sapiens*, and what he refers to the Old Testament being *The Selfish Gene* by Richard Dawkins, and then where he refers to large language models as hacking humanity's operating system, and what I represent as hacking humanity's embedding code, and that's because the way we represent our world is, data comes to our brain, it's represented into neuronal signals and binary or semi-binary, but then ultimately these are embedded into words, into language. And this is how we represent most of our world, but medicine and clinical reasoning in particular is a highly language-driven process. And so, and language is everywhere. So when I'm working with a learner, I want to see how they think. I ask them, think out loud. What is your problem representation? Explain your differential diagnosis. And in fact, a lot of work has been done on assessing clinical reasoning by really teasing out the mechanics of the language of the learner. This is work by Georges Bordage, where they looked at the discourse of a clinical reasoning. Well, again, large language models do exactly that. They've hacked by problem solving language as a substitute of knowledge, and of course, thanks to a tremendous size and processing power, they functionally, they are general purpose AI. So they're general purpose, they can do any task, including clinical reasoning and medical tasks. They're highly stochastic, a huge amount of knowledge, and they keep changing. So in essence, the similarities are actually pretty close in terms of thinking about a problem-solving agent, whether it's a large language model or AI. And that's why I think large language models are different. They're multimodal and they speak our language. Now, so could AI be used for diagnostic excellence? And so this is the gap that I want to try to close, and I'm going to give you an example. So this is a real case that we saw in the ICU at the Brigham. A 61-year-old woman with a history of hypertension, breast cancer, and recurrent ovarian cancer, presenting with a history of nausea, poor oral intake, and altered mental status following a ferry ride. So the clinical course, before coming to our hospital, she presented to an out-of-state hospital, was diagnosed with a UTI. She saw her outpatient primary oncology provider, who then refers her to the emergency room, thought she had a UTI. On day one, mental status gets worse and is intubated and transferred to the ICU. On day 3, antibiotics are broadened to vanc, cefepime, amp, acyclovir when the intern says, this could be meningitis. And then, so, okay, you said the word meningitis, all of a sudden that activates that sort of can't miss script. And then the neurology team came in, does a lumbar puncture, and in fact, the patient had listeria. So what we did here, just as an example, is I took the case, I actually took the HNP from the outpatient, the HNP from the ED, the HNP from the admission to the MICU, and the HNP like on day 3, and I gave it to ChatGPT or GPT-4, and I said, I want you to be the consultant on the team. I will provide you the history of present illness, blah, blah, blah. Give me an assessment. And on day 0, GPT-4 was concerned for meningitis and recommended to perform an LP, initiate broad-spectrum antibiotic, including the right antibiotic. It took me a few times to iterate on the prompt for it to give me the right answer consistently. But this is an example of, could we use this to nudge clinician to augment our reasoning and sort of prevent or minimize our errors? And so this idea of an AI-augmented diagnostic process is where my headspace is. Okay, now, so the hook is, how do we make this happen, right? So the problem gap hook. The hook is how we make it happen. I'm going to propose an entrustment framework, which is a similar framework that we use in competency-based medical education. In other words, what do I need in order for me to trust an AI agent? So entrustment, it depends on 3 things. Depends on demonstration of ability. So can the agent, is the agent accurate, reliable, and safe? Integrity. Can the agent explain? Is the agent transparent? Do I know how they worked? And is the agent benevolent? Are the incentives aligned with the incentives with my incentives or the incentives of the patient? And these are the 3 tenets of trust that really sort of permeate everything we do. If you think about the people you trust and you don't, it's usually measures of these 3, etc. So I'm going to start with ability. So here I'm going to go through data that's I've helped generate some that I haven't, and to demonstrate, is our large language models, and particularly GPT-4, does it have any ability? So this is some of the early stuff that got us all excited, that large language models score highly on medical exams. And so the y-axis is accuracy in answering correctly a MedQA data set of question and answers. The MedQA dataset is a dataset of MCQs that are extracted from the USMLE. And the y-axis is time, and then this is the accuracy rate of different large language models. GPT-4, this is old data now. GPT-4 scored 81.4. MedPomp-2, which is Google's version of a medical fine-tuned LLM, is 86.5. Again, this shows the data, and then now if you ask it to work on, for example, American College of Gastroenterology exam, it doesn't do as well. When I say so what, it's because multiple choice questions is not clinical reasoning. The activity, if you think about it, the activity in a multiple choice question is choosing one right answer out of 4, right? This is fundamentally what it is. It's a surrogate to clinical reasoning, but it's not clinical reasoning. Nevertheless, this is, I think, of all the studies around multiple MCQs, that's the one I like personally, but there are probably more, but anyway. So this is where they did a retrospective analysis of physicians' performance on the 2022 Israeli Medical Board Certification exam across 5 core medical specialties. And then they compared 849 physicians with GPT 3.5 and GPT 4. They accounted, this is cool, they accounted for medical stochasticity by GPT model on 120 attempts. They asked an instance of GPT-4 to answer the question 120 times because to account for stochasticity. Imagine doing that with a resident. So just take it to the data. So this is so the y-axis is the residency examination score, so percent accuracy. Passing rate is the dashed line. And then the 3 bars are GPT 3.5 in green, GPT 4 in blue, and physicians in red. On left here is psychiatry, and then OBGYN. And then you can see here that, for example, in psychiatry, the mean accuracy of GPT-4 was higher than that of the physicians. I'm not going to focus on GPT 3.5, which we know is a smaller model. OBGYN residents did better. General surgery about the same. Pediatrics, it's been consistent with pediatrics that LLMs tend to do not as good as humans. Internal medicine, GPT-4 did better. Again, so what? I think the key thing here that is what I take home from this is the fact that look at the standard deviation. I mean, at least we know that the GPT-4 is going to be reliable in its answer. But what about these physicians here? I mean, right? I mean, I don't know. This is not good. This is pediatrics. They're really not doing well. And so, and that stochasticity, I think, is important to consider. Another study looked at large language models on oncology multiple choice questions, so thinking about more sort of specially oriented topic. And here, this is really a comparison of different large language models, GPT-4 at the top, which is sort of the biggest, and then a whole bunch below. So this is the y-axis. The x-axis is the model performance. Again, accuracy on multiple choice questions. GPT-4 is better, and this is consistent across models, across tests. What I really want to show here, I'm going to skip this, is that in this particular paper, they asked the models to evaluate their confidence in their own response. So they were said, how confident are you in your response? And what they saw is that the self-assessed confidence correlated with accuracy, which I thought was pretty cool. So let's focus on GPT-4, for example, and which is the last item, item on the x-axis. The dashed red line is the model average. The yellow are the test questions where GPT-4 was very confident, and you can and the green and blue is where the GPT-4 was less confident. And so when GPT-4 was less confident, it was more likely to be wrong. If it was more confident, it was more likely to be correct. I just want to reflect on this because it's this ability to self-reflect can actually be used to make the tool transparent. And so, for example, the way I've used it in my work is there bias in your reasoning? Double check your reasoning. Is there bias in this case? How accurate are you? And these are good ways for you to get a sense of evaluate a particular tool. Okay, so now these are MCQs. Who cares? How about cases? How about problem solving? Now, there's been a lot of work around the New England Journal of Medicine CPCs, the MGH clinical pathological conferences. MGH has an exclusive deal with the NEJM, which we're not very happy about, but whatever. And so here, what Adam Rodman and Zahir have done is that this is the first study, actually, highly cited. It's a research letter in JAMA, where they took 70 CPCs, And then they took the history and physical exam data, and then they gave it to GPT-4, and then they assessed its accuracy. And what they saw is that GPT-4 had the correct diagnosis at the top in 40% of the cases, and the correct diagnosis in differential in 64% of the cases. And so, with a very high score of, and so here they assessed the, the instances in which the correct diagnosis was found. And there was no comparison to humans, but the historical comparison was around 40%. So there's a significant advantage. The next best study on solving cases is unpublished, and actually no, that's true. I think it's published. And so this is a Google study. So what they did here is they took 358 New England Journal of Medicine CPCs, and they did something really nice. And they don't use GPT-4; they used MedPalm 2, which is Google's tool. I'm actually going to move this way, so this way I'm not biased to the right side of the room. And then so they separated the participants in two groups: clinician A, clinician B. And then they gave them a case presentation in redacted form, and then they asked them to prevent a baseline differential diagnosis, so the top 10 diseases. Group A, they said, look, you can use the internet, up-to-date, Google, whatever you want. And then the second group, you can use a large language model, so you can use MedPalm 2. And then they tried to see if that changed the differential. So does the large language model affect the behavior or the reasoning of the clinician? The first thing they saw is that the most popular tools were up-to-date, 34%, Google, 30%, and PubMed, 22%. Okay, the results. I'm going to take you through them. Y-axis is accuracy in percent, meaning what percent of participants were in that area. And then the X-axis is the location on the differential diagnosis where the correct answer falls. For example, if we look at the blue line, which are the unassisted humans, right, at baseline, if you look at one, around 17% of humans had the top diagnosis, the correct diagnosis as number one on their differential. Whereas in an unassisted large language model, 30% had the correct diagnosis on the differential. And then as you go further down the differential, you can see that the likelihood of the top differential being on the differential increased, right? So for example, for humans only, around 35% of humans had the correct diagnosis on their differential diagnosis at the 10th position here, somewhere on the 10th. The point here is that if you look at the green and the yellow bars, is that the large language model, which is a yellow bar, helped clinicians increase their diagnostic accuracy. So if I was working through an NEJM CPC case and I worked with a large language model, my accuracy increased. What's in the study and not talked about more often is that they asked actually a large language model, 15 minutes, they asked a large language model to do the evaluation. So this is asking a large language model to evaluate human behavior, and it was similar, giving us insight into using large language models for assessment. So this is a study I was involved in with Adam and Steph Cabral. Here, what we did is we wanted to assess the expression of clinical reasoning. When GPT-4 gives us a differential, can it express it well? Does it write good assessment notes? Here, what we did is we took cases from NEJM Healer that were sectioned in different formats, right? And what we did is we gave random sections of cases to physicians attending MGH and BI, residents from MGH and BI, and instances of GPT-4. And then we assessed the expression of clinical reasoning using a validated tool called the Revised Idea Score. It's a rubric that you can use when you're assessing it's been validated on notes from residents and fellows to look at, is the summary, how good is the summary? How good is the differential? How good is the explanation of the differential? And how good is the assessment? And again, so GPT-4's expression of clinical reasoning was better. If you look at panel B here, on the y-axis is the score. On the x-axis are the participant. There was a statistically significant, better expression of reasoning by GPT-4. Accuracy was similar in terms of making a diagnosis, but there was more incorrect reasoning with GPT-4. Okay, this I think is a recent study in Nature Medicine, which I like. I'm gonna go a little bit faster here. What they did is that they used the Mimic4 database. The Mimic4 database is patient charts in the ICU at the Beth Israel, thousands of patients that were extracted into a database that then can be used for a myriad of things. Here, what the investigators did is that they took that data and created a data set called Mimic CDM, or Mimic Clinical Decision Making, where they broke the cases into sections: a history of present illness, physical exam, labs, radiology, a little bit like we did in Healer, and then an output of diagnosis and treatment. And then they tested different LLMs, and they wanted to see if large language models were good at solving these real cases from the MIMIC database. One huge caveat, though, is that they did not include because they could only use open source large language models. So that didn't include ChatGPT, MetPalm. So it only used open source models, which we know are not as good. So it's really, and so what they saw is that they identified 2,400 cases of appendicitis, cholecystitis, diverticulitis, pancreatitis, and then a mean. And then when you look at so on the y-axis is diagnostic accuracy, x-axis is the differential. The green bar are human physicians. Appendicitis is easy peasy. There was no difference. The accuracy was very high. But when you go into other diagnoses, there was a very stark difference. But here what they did is that they gave the whole case to GPT-4 and the whole case to the humans. And then it was actually even worse when they engaged in a conversation with the model. So instead of giving the whole case, they just gave the history, and then they said, okay, I'm going to give you the history. What do you want? And then the LLM would say, I want an exam, I want labs, etc. So really engaging in a clinical reasoning with the models. And when they look at diagnostic accuracy, here on the right, this is from giving the whole data, and you can see that overall the rates, this is the mean in here, overall the rates were much lower. So the LLMs did even worse when you segmented the data. And in fact, if you just read the sort of small thing here, small changes in the prompts really made huge changes in diagnostic accuracy. For example, instead of saying, what is the main diagnosis or primary diagnosis, you would say, what's the final diagnosis? You actually would have a different differential diagnosis. So the prompts are really critical. I'm going to skip this. This is a cool paper. This is a paper, what they did is that they looked at all the UCSF ED admissions, and they identified the sort of emergency severity index. So patients that are admitted to the ED, they're given an emergency severity index of non-urgent to critical. And then they identified 10,000 ED visits of non-equivalent scores, and they created these pairs. So this is a pair of very urgent, non-urgent, and this is a pair of emergent, urgent. And then they asked GPT-4 which one is sicker. And then they did the same with humans. And what they found, I'm going to try to take you through this, is so on the right here are the different pairs on the y-axis. On the x-axis is the accuracy. Accuracy of 1 means that GPT-4 consistently identified the sicker patient. The blue bar is the LLM, and the yellow bar is the human physicians, very similar across the board. So this is the ability of the large language model to triage patients in the ED. As we all know, I mean, patient triage is a critical step in the diagnostic process. Okay, is AI safe? So I asked GPT-4 to make an image of 2 basketball players. There's some clear errors, right? You have a hand that comes up from the foot. You have a third limb here coming out. Images are a great example to highlight bias and highlight error from these models, which I find fascinating. So here what we did is, working with Travis Zach, is we took Healer cases, and the same way that we assess the students, and then we asked it to come up with a management plan first. And second, we also asked it, give me an example of a patient with diagnosis X, diagnosis B, and try to see if, does it have stereotypes? So we asked it to create these clinical vignettes. And what we saw is that it overrepresented demographic stereotypes of diseases. So for example, if you look at sarcoidosis, the true prevalence of sarcoidosis in Black patients and in females is around 50%, let's say. Almost 100% of GPT-4-derived cases with sarcoidosis were Black female. So definitely the stereotypes of our diseases are encoded in GPT-4. And then when we asked it to give a management plan for 2 identical cases, the only difference was race. There was GPT-4 was much less likely to recommend advanced imaging for Blacks compared to white patients. But there's no doubt that there is bias. But what do we do with the bias? This is a review article that I encourage you to read in the New England Journal, where they proposed of thinking of clinical data as artifact that, when examined, can be informative of societies and institutions in which they are found. We can actually learn about biases in our society that we didn't know about through these artifacts. Now, a little bit of thinking about safety here. This is a study from Dana-Farber. Here, they used GPT-4 to create virtual oncology patients. and oncology patients, and then patient questions, right? So a question from a patient in an oncology setting. And then they asked GPT-4 to draft an answer. So can GPT-4 draft a reply to a patient message in your inbox, for example? And then they asked 6 board-certified attending radiation oncologists to respond to these messages as they normally would. So this is a manual answer to this virtual patient. Then they asked to edit the GPT-4 response and until they thought they were acceptable. What did they find? They found that the mean manual response was shorter. So humans write shorter messages. The assessing physicians felt that the large language model drafts posed the risk of severe harm in 7%. That's non-zero. And that most harmful responses were due to incorrectly determining or conveying the acuity of the scenario and recommended action. However, the physicians said that the draft improved subjective efficiency in 80% of cases. I'm going to take you through this. This is pretty cool. So this is these are they looked then at all the messages and they tried to extract what's in the message. What are the themes? Any education, extensive education, manage, inform, urgent visit. I want you to focus on act, meaning you need to do something, right? So when the manual written messages, a fair proportion of them, the physician said you need to act. When you look at the large language model draft, none. So the LLM does not tell the patient to act. What's interesting is that when a clinician actually looked at it and edited it, they didn't change it enough so that there is act in it. So the draft actually changed the original intent of the clinician. We don't know what it means. I mean, does it mean that the act is inappropriate, or does it mean that the absence of action is inappropriate? That's what we need to study that to see if this impact is possible, but it definitely impacts. Okay, so this was abilities, and I'm wrapping up. The next thing is to show transparency and explainability. And this is where, when you're working with AI tools, you need to look for scorecards by the developers, whether it's OpenAI or, for example, the Dana-Farber. So the Dana-Farber used a GPT-4-based tool and have published about it. This is a great opportunity for scholarly work where you can actually publish your work if you're working with AI tools. The other thing is to actually prompt an LLM to think out loud. And this is called chain of thought prompting. I'm just going to pause this for a second. So here, what's chain of thought prompting? Chain of thought prompting is when you tell a large language model, give me the differential diagnosis and explain your reasoning. So you it turns out that by using these words, it prompts the large language model to then, when it pulls up, it looks at this knowledge, it's looking at text where there's actually explanation of reasoning, and it increases accuracy. It's been demonstrated that chain of thought prompting increasing accuracy. And so recently, you may have noticed is that ChatGPT now includes an 0.1 version, and this 0.1 version of ChatGPT actually has embedded in it a chain of thought prompting. I'm going to give you an example. So this is a video of me using it. And so what I did here is that I put a case in ChatGPT, a clinical vignette that I actually asked GPT to create in a separate instance. And then I said, give me the differential diagnosis. So what you're going to see here is thinking. Takes time. There's a drop down that you can actually bring down, and it shows it. Assessing it's expressing its reasoning. And I think it's a way of us to really ensure transparency. And then, thought for 14 seconds, and then give me a differential diagnosis. This actually was a case this was a recent NEJM CPC. I just took the data and I gave it to it, and it was correct. And then when I show you here, so I go back up and I bring this drop down, it actually shows you its chain of thought. Very similar to what I would do with a resident or a student, who would say, explain your reasoning, elaborate. Or a consultant, a colleague, with whom I may not either agree or understand what they're saying. Very briefly, this is preprint, so it's not peer-reviewed, but this is to show that accuracy is higher compared to GPT vanilla. So this is the 0.1, so accuracy in a whole bunch of different data sets. Here they use many different data sets. Nobody's only using MCQs anymore, including the NEJM QA, which I don't know how they got, but this is basically a conversation with GPT-4. And I just wanted to show here that even though the accuracy with multiple choice questions was in 70%, the accuracy with conversational cases was actually much lower, which goes along with what I showed earlier. It's not good for conversation or decision making. Lastly, benevolence. How do we make sure that the AI tools and their developers have our best interests in mind? Well, this is where we need to get involved. Stakeholders need to get involved in the regulation, in the development. The FDA plays a role, but and then there are these non-profit coalitions of health AI companies, like Chai, for example. But the FDA actually has stepped away from these, and so which is why I'm making the case for an AI CBME, where we as stakeholders, especially educators, this is a key moment I think for educators, where we need to enforce continuous assessment of multimodal AI by stakeholder educators, patients, students, learners, where we actually give the feedback to the to decide whether or not a specific AI tool is entrustable, and if it's not, give the feedback and then have the developers work on it. I'm going to skip this. It's too much brain power at this time to go through, but this is basically making the point that if you think about problem-solving agents, we are at the bottom, right? We are problem-solving agents. We have multiple competencies, and we need a lifelong assessment. Gen AI is there, and so this argument for an AI CBME. And how could we make the assessment? So if I was developing a tool, well, what I would do is I would actually leverage this EPA scale. How much can I trust a particular tool? And then the same way that it's used in student to drive educational interventions, it can be used in AI to drive tool modifications and then make these certification decisions. Thank you.
That was absolutely splendid. Thank you, Dr. Abdulnour. Lots of questions, lots of things, and there's lots in the chat. We'll take a recording of those and perhaps forward them to you, and perhaps you can answer them when you have time, or send them to chat. GPT-4.
That's exactly what I was going to do. But yeah.
So, wow, there's so much to talk about. But if one of the things that we talk about in terms of accuracy, there needs to be a gold standard. And I get it, when there's a test that tells us they have SARS, or there's a positive gram stain and so forth. But what do you do in analyzing this? Take, for example, the differential between something as simple in your area as pneumonia versus congestive heart failure. How often, and there's been a lot written, we don't know the diagnosis. And how is AI going to use that? Because there is no gold standard for that diagnosis.
It's a great question. And I say it's a great question, because what is a gold standard? And I think in areas where certainty is high and attainable, like in math or physics or in basic science, and some basic science, it's easy to have a gold standard that's actually objective and quantifiable. But in forecasting fields, and I use it specifically like mimicking what weather. We are basically weather people. We predict something. In forecasting field, the gold standard cannot be the same. And what we've done there is we assume the gold standard is whatever a highly entrustable human agent comes up with. So, for example, if for this particular question, if I have 5 or 10 clinicians that I know are very able, are very transparent, and are very benevolent, and are probably at the at the peak of their game, whatever they come up with is what I'm going to consider a gold standard.
Okay, well, thank you very much.